Hi, I'm Colleen Fisk. I'd like to talk to you about Bill S-804, the Women's Veterans Access to Quality Care Act of 2017. The bill was initially sponsored by Senator Dean Heller, the senior senator from the state of Nevada, and co-sponsored by Cynthia Murray, a senator from the state of Washington. The goal of the bill is to establish a set of structured standards to meet gender-specific health care for women veterans in all VA facilities across the United States. There currently is no standard for women's health services in those hospitals. Well, the bill specifies a lot of reports and evaluations and assessments. Some of the ones that I'd like to talk about today are if the bill's enacted, that within an 18-month span of time, every VA facility will have to have at least one full-time OBGYN physician within it. And within 2 years' time from the enactment, at least 3 of the integrated services networks out of the 18 that the VA currently has will have to participate in a pilot project broadening the number of slots for OBGYN residency and women's health care residencies, which should help increase the accessibility for women veterans to necessary health care. Another piece is the quality assurance piece of this bill, where they are going to directly tie women's health outcomes and metrics to medical directors' performance evaluations. And those evaluations and metrics will be publicly published on an internet site where they can be viewed by everyone and compared to civilian hospital data, so that we are all striving to be better facilities and to meet the needs of our veterans who desperately need our services. Other evaluations that will be going on as part of this bill will be reports based on average wait times for women veterans. Wait times have been in the news a lot lately. Whether they have a clinic specializing in women's health, the number of full-time OBGYNs they have currently, the number of professionals trained in women's studies, whether the facility conducts regular sensitivity training and women's health issue training with their staff, the differences in healthcare outcomes between women and men, the extent to which the center implements all directives from the Center for Women Veterans, which also comes from the Women Veterans Health Handbook, and an outreach piece by the Department of Veterans, who will collaborate with academic and civilian facilities that are local to collaborate on best practice and how best to serve this population, which I think is really exciting. Historically, women have served in the military since the Revolutionary War. They've carried water, they've bandaged soldiers, they've delivered food and cooked food, they've couriered messages, and due to the fluidity of battle lines and changing strategies, frequently have ended up on the front lines. They've been prisoners of war, they've been maimed, and they've been killed. But for many, many years, when it no longer suited the military, they would send them back to their homes and tell them they didn't need them anymore, frequently putting little trained men in charge of caring for soldiers who really didn't have any understanding of what that meant. There was so much resistance to women being allowed to fulfill certain roles in the military that during the Vietnam conflict, 300,000 men with low aptitude scores who would not normally have been inducted into military service were brought in before Congress finally authorized the expansion of women's roles in the military in 1968. And part of that was due to the impending ending of conscription, which is also known as the draft, compulsory military service during times of need. Once that ended, the number of women in the military exploded exponentially. Induction criteria was equalized with no more restrictions of numbers of officers or non-commissioned officers, no more restriction on whether or not men could report to women. Pregnancy, marriage, and dependent children were no longer a reason for discharge. And by 1980, all restrictions on roles except combat had been lifted for us. And while we have made many gains in military service, we have also suffered some dire consequences. Military sexual assault, military associated trauma, and sexual harassment bring with them long-term health implications, and the need for parity in women's health in veterans hospitals for those benefits that they have earned is imperative. Post-traumatic stress disorder, depression, anxiety, substance issues, all can be part and parcel of military trauma, military sexual trauma, and even lifetime trauma that occurred before they entered the military. In relationship to relevance in nursing practice, the VA has been under fire for a number of years for poor quality health care. And after a variety of reports between 2010 and 2014 of people dying waiting for appointments and audits of military records, the Office of Inspector General did come out and say that while they were unable to exclusively determine that any of those deaths were related to not getting appointments soon enough, they did identify that the hospitals were providing poor quality care, and that was the impetus for the first Veterans Choice and Access to Care Act of 2014, and that allowed veterans to choose where they wanted to get their care. If their wait time was going to be more than 30 days, then fees would be authorized to receive the care in civilian hospitals. We're trying to bring the care back to veterans-associated hospitals, and if it's feasible and financially, it can be financially solvent, then I think that that makes perfect sense. In addition to relevance in practice environments today, everybody is being pushed to have more positive outcomes. We all have quality measures that we have to achieve, and those benchmarks are derived from top performing states and hospitals, and we all have to, rush to catch up. CMS, AHRQ, the Joint Commission all have public reporting of health outcomes and survey. Performance-based incentives are the wave of the future, and it's logical that the VA would be held to the same standard as the rest of us. Nursing sensitive indicators actually have been developed and tested and implemented in organizations by ANA, Veterans Health Administration, and the Association of Perioperative RNs. And these indicators show nursing's commitment to high quality care. We want less infection, we want shorter hospital stays, we don't want bad outcomes, we want to take good care of our people. So these nursing sensitive measures have been identified and are now included in surveys by CMS and Joint Commission and being taken very seriously. So we are doing a good job of advocating for our patients. S804 is intended to hold VA facility staff accountable for achieving quality measures, just like we're all trying to achieve them in our civilian hospitals. There are standards for mental health care being implemented. The Joint Commission has a guideline through Sentinel Event 56 with recommendations for starting mental health assessment at the time of outpatient appointments, giving everybody a simple standardized tool, PHQ-9, PHQ-2, for the patient to fill out, and for that tool to be screened before the patient leaves from that appointment that day. What they found is that it's not reliable for the patient to come forward and say, I've been depressed, or I'm anxious, or I can't sleep. It's much easier for them to put it on a written tool and not have to talk about it initially. Due to stigma and embarrassment and guilt and spiritual issues, they're much less likely to talk about that, but they'll fill out a written tool and be more honest. If that tool is positive, then a secondary screening needs to be done with a behavioral health clinician or a more in-depth tool such as the Columbia Suicide Assessment Scale. And then further care can be decided after that, whether that patient is high risk or low risk, and what will we do to take best care of them, whether it's an inpatient stay or organizing outpatient treatment, putting together a safety plan, not a contract, but a safety plan. So following those kind of guidelines in VA hospitals and community hospitals all makes sense. We should all be doing the same thing to provide consistency and good care for patients. As far as the research piece and how this is going to benefit public health and veterans alike, what we've found in research is that the trends are that there are some barriers to care for women. Some of it is a lack of access for women's services, but it's also lack of childcare, lack of feeling safe when they go in for an appointment and there's a lot of men around. If they've got military sexual trauma, then they're not likely to want to stay in those areas. So coordination of care with specialized services in areas for women can go a long way towards making them feel more secure and allowing them to get their medical care in a place that's really meant to serve them and their variety of specialized issues. With a host of mental health stuff that can come along with serving in the military, it only is fitting that we would provide a good environment for them to receive their health care in. So studies on small populations have shown that women veterans are a very vulnerable population, that they are more likely to go without care. They don't know how to access care. They don't think the care is meant for them. Financially, they have barriers. They can't take off time from work and pay for extra daycare for their kids so they can get to the hospital. So all of that through care coordination and resources can be made available to veterans so that we can take better care of them. If S804 is enacted, it should improve access to gynecology, maternity, infertility, breast and cervical cancer screenings, uterine cancer screenings, mammograms. If the health of veterans improves, then the health of our communities improve. A decreased suicide rate of veterans, because we're doing better with mental health care, is a possibility, which also decreases our cost. Folks with mental health issues, veterans with mental health issues, are high utilizers of services. So if we can catch it in the outpatient setting and not have to do inpatient hospitalization, then financially it's more solvent for all of us. So I am endorsing S804 for all of those reasons, and this was a very short amount of time for me to get all of those points across. But I think it makes perfect sense for us to take care of our veterans, whether they be men or women, and that services will have to be increased throughout VA facilities with all the women who are starting to search for veteran services. Accessibility is going to be a problem, not only in women's health issues, but in cardiac issues, in neurology for TBIs, social services for lack of employment and housing and all of those things. I think S804 makes a great step forward and will allow us to build on other healthcare acts that have gone before us and start to take better care of our veterans and inevitably better care of our communities. Thanks for listening.